to the next installment of the Survivor Core webinar series, because we know that you can't always get to the experts. So Survivor Core is here to bring the experts to you. And today we have two amazing experts, one pulmonologist and one cardiologist, both from Mount Sinai, Dr. Bander and Dr. Steiger. And I'm going to introduce them in a second, but first I have a really, really exciting announcement to make. Next week on October 13th from 5 to 8 p.m., we are doing an antibody party, because there's no pandemic party like an antibody party. Survivor Core and Mount Sinai together at Mount Sinai Hospital at 1184 Fifth Avenue at the G1 Center. You can register for free antibody screening. Okay, and it's not just any kind of antibody screening. It's the famous Mount Sinai test that gives you your titer number. I know you're all dying to know. This is how to get your titer number. Why? Because based on your titer number, you can then go donate your plasma. If it's on the lower end, you can donate for patient transfusion. If it's on the high end and you're a super donor, you can donate hyperimmune globulin product. And I'll let Dr. Bander talk about that a little bit more in a second. But the most important thing is that you got to sign up. And the most exciting part is that the first 375 people who sign up will get a Survivor Core mask. So go sign up immediately. And it's all free. Okay. So we have with us two incredibly accomplished doctors, Dr. David Steiger, professor of medicine at the Icahn School of Medicine and chief of pulmonary and critical care and sleep medicine at Mount Sinai West and Mount Sinai Beth Israel. Dr. Steiger has worked in the Mount Sinai system for over 5 years. And I could go on. Forget about that. We have too much to cover. We have too much substance. Sorry. We're going to do top end on this stuff. Dr. Bander is the chief of cardiology at Mount Sinai in interventional cardiology and cardiovascular disease. And more pertinent to this group, he is the co-director of the Mount Sinai Heart Post-COVID Evaluation and Monitoring Program, an outpatient cardiology program for evaluation of patients with new onset cardiac symptoms post-COVID infection. Really, really good for everybody to know. So first, Dr. Bander, can you talk a little bit about why you're doing this antibody drive, or why we are doing this antibody drive, and a little bit about the post-COVID cardiac center, and then we're going to launch into questions.
Sure, no problem. So first of all, thanks for having us on. I think that when we first started talking about the antibody drive a few weeks ago, it was COVID in New York was all post-COVID, and I think unfortunately it looks like we're back in. As we predicted, fall would be back. Well, fall came early this year. And there's a decent number of uptick in certain counties in New York with COVID, which translates to more hospitalization. So definitely been an uptick, not just in COVID cases, but in the need for plasma. And the data out there since the EUA has been somewhat positive, shows that the plasma does have benefits. So antibody products, whether they be convalescent plasma, immunoglobulins, just super concentrated plasmas that's sorted out, or these monoclonal antibodies that Trump got. These are all part of the armamentarium that we use against COVID. So we need the donations as much as we can get to make these products so we can make them available. So thank you to Survivor Core for helping us with that.
Can you just clarify on those? I know that everyone's been talking a lot about monoclonal antibodies. Those are also derived from plasma?
No, so those are, well, originally just to get to the point, as you were saying, was that, they originally came from one donor who had a really strong antibody. They took what's called a B cell and they cloned it, and that B cell produces mass quantities of one specific antibody. That's the monoclonal, that's why it's mono. So, but they're all along the same lines, they work the same way.
Interesting. Okay, great. So please go sign up. And okay, so let's just start from the beginning with COVID here. We've got the two specialists here. We've started out, the one thing that I guess we've learned a few things in the last 7 months or so. We started out really referring to it as a respiratory disease, and it's now referred to as a vascular disease. Can you guys both sort of weigh in a little bit on, obviously it's still impacting the lungs, but what is this virus, and, how did it go from one to the other, and what does that mean?
Jeffrey, do you want to start, or should I start?
No, you go ahead. Since we started as a pulmonary virus, we'll start with the pulmonologist. So.
Okay, so this is a virus. It comes into us via droplets, so we can inhale them. It can actually enter through our mucosal surfaces, through our eyes, for example. So you hear scientists and lay people talk about the necessity of wearing masks and also covering your eyes as well if you think you may be exposed when you're outside, particularly in crowded areas. So the virus enters, and the main portal of entry is the nose and the lungs, and we see lung injury and we see other symptoms. It's a virus, so those of you who've had the flu know that you get so-called systemic illness. You get muscle aches, myalgias, arthritis, headaches, neck stiffness. And from a pulmonary perspective, you get shortness of breath and cough. The most common symptoms are loss of sense of smell, loss of sense of taste. And this is a new symptom. We found that it was quite characteristic of this disease. About 10% get tummy upset, nausea, vomiting, diarrhea. Most patients get headache. Fatigue is a big component. Not everybody gets fever. Some people get chills. Some people don't get fever at all. But as a pulmonologist, I know that the majority symptom is cough, sometimes with phlegm. It's usually a dry cough. Shortness of breath, which can be progressive or not, depending on which way the disease is going. And a kind of atypical chest pain. Jeffrey's going to talk about cardiac complications. The chest pain I'm talking about, often it's not cardiac. It's unclear the cause. It could be inflammation of the lining of the lung.
I felt a tremendous pressure on my chest when I had COVID. Like I felt like I had a baby elephant sitting on my chest.
Yeah. So if you were to ask me what is the exact cause of this, we don't know. We know there's inflammation going on in the lung, in the alveoli, in the air sacs. There's lung injury starting, and patients get what I call pneumonia, COVID pneumonia. And that's the most frequent cause for admission and unfortunately for mortality as well.
And so then we find out, Dr. Bender, what's the next bit?
So I mean, it goes, it's you know, yeah, it goes in from the lungs and it does all that damage, and you know, which is why people get hypoxic in there. You talk the O2 sats dropping, that's from that damage. But you know, we found out, you know, pretty early on, or a few weeks into the disease, was that, you know, the way the virus enters the cells is what's called the Ace2 receptor, and that receptor is everywhere. It's almost on every organ, but a lot on the vasculature. So the lungs have their own arterial systems, and the rest of the body, the heart and everything. So this virus can get in everywhere. So that's why you guys are experts in this, knowing that almost every organ system can have long-term effects. Why the vast majority of people don't have it, we don't know, but we certainly see people have everywhere. But what we do know is that, as you said, it's a vascular disease. So these receptors are on the vessels, and then they have endothelial dysfunction. And most importantly, they can cause blood clots as well. So, you know, one of the first tools that we learned early on, besides, you know, the lungs and the respirators and treating the virus, was that we had to address possible clotting. And so people often now are on blood thinners, and we can talk a little bit about, you know, aspirin. But yes, the virus itself is not just affecting the lungs, but affects the vasculature, and therefore blood clotting and inflammation seems to be one of the key aspects of how this disease devastates patients.
And following on from that vascular injury, unfortunately, we see patients with strokes. In fact, Mount Sinai described a case series of strokes in young people from vascular injury. And
we have many members who have experienced just that.
Yeah, yeah.
So knowing that, I've been asking this of everybody, but why, you know, understanding that most patients who are discharged from the hospital with COVID are put on an anticoagulant for 60 or 90 days, but nobody who has the Tylenol and Gatorade variety of COVID is under any medical care. So nobody is giving that sort of advice. Should we all be on an aspirin a day or more? Should people be on it preventively? Would it help once it's already done its damage? You know, why would you not be?
Okay, so I could answer that in a number of ways. For hospitalized patients, for those patients who are sick enough to require hospitalization, the standard of care is both during hospitalization to give them blood thinners to prevent blood clots, to give them higher doses if we think they have a blood clot, or if they're critically ill and haven't had a blood clot but at risk of a blood clot, we put them on full dose anticoagulation. So there's a whole spectrum. For patients who are hospitalized or ready to go home who have not had a blood clot, we give them prophylactic anticoagulation. These are pills, a new generation of blood thinners have been around for about 6 or 7 years, easy to use once a day or twice a day at lowish dose. Jeffrey will agree with this. For every decision we make as physicians, we have to balance the risks of giving a drug versus the potential downside. These are blood thinners, so they can cause bleeding. Now, the kind of doses we are giving usually for those patients who don't have blood clots, but because they have COVID, they're at risk of blood clots, usually kind of lowish dose prophylactic doses. If you were to ask me, how long should patients who are leaving the hospital be taking this? No, we don't know. We don't know. So what I do, and I imagine we'll have questions about this, when we see patients in the outpatient clinic who's still symptomatic, I check some lab tests to see if there's still persistent inflammation. And in particular, we look at a blood assay called a D-dimer, which many of you are familiar with, and it's a marker of blood clot breakdown. If the D-dimer is elevated and above the normal level, that suggests there's a large clot burden still, and there's clot being broken down. And then we have to be concerned that there may be both small clots and larger clots, clots in the leg and the lung, life-threatening. I have admitted a number of patients from my clinic who've had elevated D-dimers many months after discharge from the hospital. So, secondly, and lastly, so I don't monopolize the conversation, you're asking, what about our patients who are not admitted, right? Well, they have to be evaluated by physicians. They should find out if they have inflammatory markers that are elevated. The blood clots are from inflammation, the systemic inflammation, as Jeffrey pointed out. And the D-dimer is just one of a number of blood tests that show inflammation. If inflammation is ongoing, the patient may benefit from a blood thinner. Do we have any data on showing the safety and efficacy, i.e. preventing blood clots in outpatients who are never admitted with blood clots? We don't have that data. So again,
is there any real world evidence that could?
I don't think we have enough. We don't have enough literature, but I think all of us as physicians, if the patient still has elevated inflammatory markers, we weigh the risks and benefits of giving lowish dose blood thinners. And many of us would be proactive, I think. Is an aspirin sufficient? Aspirins have been used for prophylaxis in both cardiac and arterial disease and venous disease. And venous disease is what's happening with blood clots in the leg, and then they go to the lung. That's called a pulmonary embolism. So if you can tolerate an aspirin is a minimum, either low dose, 81 milligrams, once a day, 3 times a week. That's not a bad idea.
Yeah, I would say in your, as you described, the Gatorade and variety where you're home and you're not having medical contact, if you're not high risk for bleeding, aspirin's over the counter. We're not prescribing it, but I again, first principles, I think that's okay. If you cannot get in touch with a doctor, agree with David. If you can be, that's the way it goes. And we have plenty of patients that do video consults with us who have COVID now. We don't lay eyes on them. We look at D-dimer, CRPs, and decide fibrinogen, decide what dose of blood thinners. And aspirin's an antiplatelet, but the medicines we use are different. So if you can get in touch with medical therapy, that will be good. Now, in terms of duration, if you've already recovered from COVID, I agree, the D-dimer is the best way to go. But if you don't have contact and you're better, the risks of long-term anticoagulation stronger than aspirin probably are outweighed by the risks of it. So the benefits are outweighed by the risks. So I would say 30 days afterwards, I would not give unless you have a high D-dimer.
Okay, that's actually super helpful, practical advice, which is what we're going for. I have so many questions from our members, and so we're going to do kind of like, I won't call it a lightning round, but we're going to have a lot to go through. So in terms of testing, a lot of the people's questions revolved around what kinds of tests should they be getting if they, we're hearing all these stories about people having heart damage, myocarditis without, being asymptomatic. I just went for an echocardiogram yesterday, got a full clearance, heart looks great. But, I know that neither of you do pediatrics, but what do we do if we've had COVID? What tests should we be seeking out just as screening on behalf of ourselves and our children?
So one thing, I think it's interesting that, you read a lot in the literature says a lot about, post-COVID symptoms. I would still say though, that even though the majority of patients, if you screen them, have symptoms, the vast majority don't have so many symptoms that they end up presenting. And some people may be underreporting, but, in terms of cardiac issues, we see a lot of patients with cardiac complaints and we don't find it. However, there is a certain subsegment that do. So my recommendation tends to be, if you have significant chest pain or palpitations and you've had COVID or you think you've had COVID, you should come and get checked. Now, what test do you do? If you've already had it in April and in March, the swab is useless. So antibody testing is probably the best way for you to document that you've actually had COVID. Now, some people don't mount an antibody response, so just because you've zero doesn't mean that someone's saying we're not saying you don't have COVID. But the vast majority of people who have COVID will have antibodies. So that is the first step to take. And then I think seeing a regular doctor doing an EKG, just listen to your heart, see if there's other reasons, that's the best place to start. From my end, I recommend that people end up presenting to a cardiologist because they have persistent, palpitations, chest pain, shortness of breath. an echo and an EKG is a great place to start. And then we give people a Holter monitor, which is an EKG for a day or for 7 days that continuously sees what the palpitations are. That's what we do. And then the inflammatory markers. So that's in a nutshell.
From a pulmonary perspective, as above, I would take a history, find out how symptomatic the patient is. If the patient has made a good recovery, we may back up, but we'll send off blood tests, see if there's active inflammation. We'll check the D-dimer, because for the differential, if the patient's short of breath, it could be cardiac, it could be pulmonary. If it's pulmonary, it could be the lung tissue itself, and we'll need to do a chest X-ray, but probably a CAT scan. I'll explain why in a minute, to see if there's persistent inflammation. It could be pulmonary vascular. So here it's not the pulmonary tissue, it's not cardiac, but it's in between. These are blood vessels that go from the heart to lung. I mentioned blood clots can occur in patients many months after. So I would check a D-dimer, and if that's elevated, I would do a CAT scan with contrast injections, see if there's a blood clot that can be treated. In the absence of an elevated D-dimer, I would probably do a CAT scan. We have learned that the chest X-ray is too insensitive. If a patient is symptomatic, I could do a chest X-ray, but I think I'll be wasting the patient's time. And I think we just go straight to a CAT scan and minimize, maybe ask for low dose radiation to minimize the amount of radiation. After all, if the patient's been hospitalized, they've already received a fair amount of radiation with all the diagnostic tests they required. They may have already had a scan. So if I order a scan, I try to minimize radiation of a low dose radiation. Secondly, I order pulmonary function tests. The patient's short of breath. The pulmonary function test complements that with a CAT scan. The CAT scan gives us pictures. The pulmonary function test gives me an idea of physiology in reserve and see if there's been damage to the lungs. And so we look at numbers, and then I can show the patient the numbers are an expression of underlying lung function or dysfunction. And the hope is that there will be improvement if there's a reduction in lung volume from lung inflammation. That should improve. So again, in summary, blood tests, pulmonary function tests, imaging test, probably a CAT scan.
So because a lot of people are going to their doctors, they're having tests done and the tests are coming out inconclusive. So that's sort of the progression of tests to go down to like keep on drilling down to find what is going on, because a lot of these things are not showing up in any, you know, people are having palpitations or having all of these ailments and the tests just aren't coming up with anything, is that they're, you know, just not, you know, being tested far enough? Or are you encountering this with your patients? Are you seeing this where it's just sort of mysterious?
You know, these, you know, the viral syndromes, you know, post-viral syndromes that we have in cardiology existed before COVID. So, you know, and I just think that COVID's brought out a lot. So,
can you compare it with other post-viral syndromes? Because I mean, there do seem to be similarities, but also substantive differences, right?
Well, from the practical level, I'll say, I'm not going to speak specifically, on a practical level, you know, we have two conditions that we see in cardiology: pericarditis, myocarditis. And those are the syndromes that cause the chest pain when lying down, or, you know, this tightness in the chest that feels better when you sit up, or, you know, the palpitations, feeling the heart racing. These are kind of very nondescript symptoms that people get when they have no underlying condition. It's just the heart racing and from anxiety. That's why it's so difficult to tease it apart. So what we're seeing is that a lot of people have these symptoms and they're not related to COVID, but a lot of people, some people do. So it's shifting through all those patients. So I do think it's very much worth people who suddenly have these symptoms after COVID, who went to their doctor, they don't find anything on an EKG. EKGs are really non-specific. If they continue to have these symptoms and they persist, to get a basic check from, you know, a cardiologist or a pulmonologist. And that's why we have these kind of centers that we're trying to bring online. We just brought our cardiologist, I know Dr. Steiger is working on his, but coming in for an echo and a monitor really is not a big test. It's a 20-minute test and a monitor where really will help capture about 95% of the people that have it. Those that we need more testing on, we just made a cardiac MRI, will show that inflammation in the heart. And that's really what, when you look at the studies, people say, oh, 80% of people have heart involvement. Well, if you do a really good enough test, you'll see some lighting up on an MRI of the heart. And in most people, it's clinically insignificant. So we have to find those that's really affecting, those that need to be treated.
So if you have but if you're not having problems, you don't think that any preemptive screening is necessary, even though we're seeing these very scary stories?
Yeah, I think that, you know, if you're worried, I don't think there's any, since we don't know, let's be honest, we don't know enough, right? We don't know enough. So for me to say, don't worry about it is not coming from anywhere. But I think it's worthwhile if you've had COVID and you're worried, I think it's indicated enough, since we don't know, to get an echo that will at least tell us if there's any massive inflammation or massive, vast majority, vast majority, I'm saying in the 90% high range, won't have anything at all.
I just had mine yesterday, came back completely clean.
Exactly.
So.
But, in cardiology, we're very risk, since it's such a sensitive place, one heart attack, one issue, we don't take a risk. I don't think it's a bad idea to get checked out, to get an echo, to get an event monitor. If you're having palpitations, it's to monitor. If you're having chest pain or shortness of breath, and, it's balancing between me and Dr. Steiger about whether or not, is it lung or is it heart? And we won't know that till we see you. But if you don't have symptoms and you want to get checked, yes, but you don't have to.
So
Speaking of that,
with respect to your question, just to add to what Jeffrey was pointing out, so I've had patients with chest pain, and they have a cardiac evaluation, they have a pulmonary evaluation. We do the test that we just discussed a few minutes ago. Unfortunately, I still have patients who have persistent pain, and I'm not sure as to the cause. It's possible they could be from microthrombosis, small blood clots, what we call pulmonary infarction that we don't see in the CAT scan. So the imaging study does not provide sufficient explanation. In some patients, I still see persistent inflammation for those that we're giving steroids. How long should we give steroids? We give them sometimes up to a month. Okay. For those who don't have any evidence of inflammation on the CAT scan, that is, sometimes we give steroids nevertheless because we believe, just as Jeffrey talked about pericarditis, inflammation of the lining of the heart, the patient may have pleuritis, inflammation of the lining of the lung. Is there good data on this? No, but we give safe doses. We describe the potential side effects of the steroids or anti-inflammatory agents, and we'll see most patients improve. In some, I've been impressed that it takes a long time. Some patients have persistent pain. I use a drug that Jeffrey uses, colchicine, at a lower dose than normally given for more severe inflammation, and I've had some success with that.
I think the key is individualizing the therapy. So it's really, if you're at home and not seeing anyone, it's really hard to say. But if you have persistent symptoms, come in and get checked out.
In this split between cardiac and pulmonary, there are questions about, we've heard that perhaps the virus attacks the vagus nerve, or this is a form of dysautonomia. We've heard all these things bandied about. What's to make of that, or is it just attacking your heart and attacking your lungs and that's it?
Well, as you said, it's attacking everything. And I think that's, again, one of the things that we don't know. I mean, there's called COVID brain that people talk about, this fog.
Yeah. And
it's been demonstrated to be in neural tissues as well. So sure. And I think, again, people who have an underlying, history of kind of a POTS type syndrome or hypotension, they may have dysregulation and dysautonomia. But that's something that we don't know how to treat well. We'd probably still treat it with the same conservative measures, which is, hydration and salt. But yeah, we have some, and I was speaking earlier, we have a dysautonomia center, which I can send out to you afterwards at Sinai. They're pretty backed up, but I think for difficult cases, we can recommend that people go.
Yeah, that would be great to get that information. So one of the weird things about COVID and long-term COVID is the way it sort of like comes and goes. A lot of the symptoms come and go, and often people describe it as like waking up in the morning and reaching into a shopping bag and pulling out symptoms. What do you make of people who are having shortness of breath one day and not the next? And, their routines haven't changed, or they're having a month of it. And then, it seems to be coming, for a lot of people, it's coming in waves, or it almost feels like relapses. Is the period between the relapses going to get longer? Is it going to go away, or is it caused, or will it have caused too much permanent damage in people to permanently go away?
There's a lot of questions there, and I provide a number of answers, and I'll try and be coherent. Number one, for most patients, there is damage, and the damage heals. So from a lung perspective, there are patients who have persistent damage. They have fibrosis of the lungs. And in addition to steroids, and I'll tell you where I work in a minute, we're providing experimental drugs to see if we can address the progressive fibrosis, which we see in pre-COVID days, and patients have severe lung injury, whether it be viral, bacterial, drowning, sepsis, whatever. They have lung injury and fibrosis. That's the end stage of inflammation. There are drugs available. We give steroids, and there are experimental drugs. And there's a drug that we use for pulmonary fibrosis that we are now retooling in a trial for patients with pulmonary fibrosis. But you're right, there are some patients I've seen who have improved, but they get intermittent symptoms. One key thing about this disease, in common with other viruses, you had referred to that, fatigue. I'm quite sure that when one is fatigued and debilitated, because this is a debilitating disease, where patients can take months to get back to where they normally. And these are young people as well, normally in great cardiopulmonary health, people, avid exercises. Fatigue plays a big role in how we perceive our symptoms. And I think that can, and insomnia and sleep dysregulation and interruption of sleep because of anxiety about the disease and the natural history and uncertainty. I think this is impacting as well how we perceive our symptoms as well. I think that's playing a role. If you're asking me to give a biological reasons why these symptoms come and go, I can't give you a good answer. I don't think we know enough. But the symptoms are real. I have no doubt about it. And I think for most patients, they will resolve. Unfortunately, we don't know. Look, the first COVID survivors, thank God, were from January, February. This is still early days.
Yeah. Dr. Bander, do you want to weigh in on that?
Yeah, I think that it's at this point, since we don't know everything, we have certain tools in our armamentarium. We talked about pulmonary fibrosis retooling. We have, and again, steroids, again, comes back to how we're treating current COVID and post-COVID. It's an inflammatory condition. So, and we have, for patients' palpitations, we have beta blockers, we have other things, we have other tools. So I think it's really individualizing for the patient. There's no real thing out there like, should you take vitamins? People ask you all the time. Well, we say vitamin D, vitamin C are the ones that have some data behind them in terms of preventing COVID, treating COVID, and boosting your immune system. We just don't know enough yet to say, which is why come see us and we can decide, do you need steroids? Do you need something else for your post-COVID symptoms?
You mentioned exercising, Dr. Steiger. I will say I don't feel fatigued at all, but I cannot imagine doing cardio exercise. And I had COVID 7 months ago, and I was an avid exerciser before that. And we're seeing a lot of post-COVID or long-term COVID issues with people who were young and really, really in shape. A lot of former fitness instructors in Survivor Corps, I notice. What's the connection? And the second half of that question is, if I had COVID, is it, should usually, like, one of the things you do when you're trying to get better from something is exercise, but exercise seems to be knocking people out, like literally for days. So can you talk a little bit about, are you more susceptible as an athlete perhaps to, I'm not talking professional athlete, but if you're athletic, and then how should you manage sort of hopefully getting back into some sort of physical shape afterwards?
So first of all, I think the causes for debility are multifactorial, many causes. So the illness causes loss of muscle mass, deconditioning, loss of weight, a loss of cardiopulmonary reserve. You and I know that if we have the flu, we're wiped out for a week or two, sometimes even longer. Patients who have Epstein-Barr, for example, can get fatigued for a long period of time.
Right?
So yes, so that's factor number one. Number two, in those patients who unfortunately have incurred damage to the heart and or lungs, there's healing, and we don't know the natural history. We know from, this is a coronavirus. We know patients who had SARS and MERS in 2003 and 2010, respectively. Some of these patients who had damage to the lungs, we know from pulmonary function tests that physiologically, it took months, sometimes a little longer, and a significant number of patients to heal their lungs and get back to where they were. So part of it is from the general debility from the illness, part of it from what's known from coronavirus, other diseases in 2003-10, and the damage to lungs and perhaps the heart as well, we have discussed. So what's the solution? Well, exercise. So I mentioned that I work at the National Jewish Respiratory Institute downtown at Union Square. And I work with colleagues who work at the National Jewish Respiratory Institute uptown at the main Mount Sinai Hospital. And so we get referrals from the Center of Excellence, which is Mount Sinai, established in Mount Sinai, downtown Union Square, where primary care and multi-specialists, infectious disease, neurologists, cardiologists, people interested in rehabilitation, psychologists, psychiatrists, social workers are all involved in comprehensive care for these patients. And then these patients are referred to cardiologists like Jeffrey, to pulmonologists like myself, at either downtown or uptown.
I've been very lucky to be a patient there at the Post-COVID Care Center, and I think that everybody in this group is on the waiting list. It's either been or on the waiting list for years into the future, or live elsewhere and are trying to demand that a similar center be opened where they live. So it is incredible, but unfortunately it's been only made available to a very small fraction of the people who need it. But it is truly a model for what needs to exist everywhere.
Yeah, and I think that's again, as part of your organizational part, is taking the things that we're doing here in New York, because we were early on as a big academic center, and then being able to find out what we're doing is not magic. There's only a few tools in our chest, and those can be expanded to elsewhere. The same tests that we run, the same things that we use can be expanded, and we can help with that. But you're right, the need is greater than the availability.
Yeah.
Diana, just in terms of numbers, I wrote them down here. So over 8,000 patients have been discharged from the Mount Sinai system. So survivors, and the majority of people survive. And Mount Sinai has evaluated 20,000 so far COVID patients, both inpatients and outpatients. And that's just one hospital system amongst many in the New York metropolitan area, which is just part of the United States. So that's the size of the problem we're dealing with.
Yeah. Oh, believe me. Yeah. No, the problem we're dealing in the millions. We only have a few more minutes, and I want to get a few more questions in. When I had COVID in early March, I had never heard. I still don't even know how to pronounce it. The device that measures your oxygen.
Oximetry. Yeah. Oximetry.
Yes, what at what point do you go to the emergency room? How low does it need to go?
So, right now we're telling people when you have active COVID. So if you're post-COVID and your oxygen's low because you have lung damage and you get it down a little bit to the low 90s, I don't think that's, and it's remaining, that's not an issue. But we tell people now who've current COVID, if your O2 sat is less than 94%, then you become a candidate for these advanced therapies, like Trump talked about, like he got remdesivir and antibody therapy. So 94% is kind of our number now. For current
like this person saying their oxygen levels are dropping to the 80s at night.
So, Dr. Steiger, that's a sleep apnea problem.
So with all patients, and this is the art of medicine, I'd like to know if this patient had any lung disease before. And it's a truism that what your O2 sat during the day is always higher than it is when we're asleep. When we're asleep,
right,
we cannot augment our own respiratory efforts. Just we rely on, it's like a heart pacemaker, on an intrinsic rate. But that's too low, so that needs to be evaluated. And is it all from COVID? There could be other things going on as well, but that patient definitely has to be evaluated because that's dangerously low.
That is okay. That's good. Are there, Dr. Steiger, since we're on lungs, are there pulmonary exercises that people can do on their own to build back strength and things like that, in the same way that I would ask Dr. Bander, like how one builds your heart stronger, but I imagine the answer to that is sleep and exercise and eating well.
Right. So there's a field called pulmonary rehabilitation, which has been around for a fair amount of time. It's for young people and old people with advanced heart and lung disease. And so it's like having a personal trainer. You go into you can either do it in a lab or an outpatient center, or you can be taught. It's a treadmill exercises, gradually increasing your exercise duration and endurance, and it's targeted as well. We use the pulse oximeter you mentioned, ensuring the oxygen level is stable, and hopefully with improvement in heart and lung function, which is what we do with exercise, and improve endurance and improve sense of well-being. So these are all the kind of metrics that we follow. So exercise, yeah. And is there a unique kind of exercise? Not really, walking.
Walking is fine. It doesn't have you. It doesn't have, you don't have to get into that high cardio level.
Yeah, I mean it's about having a sustained, for the cardiac wise, it's having sustained pulse for greater than 20 minutes. As your trainers who are on will tell you, right? That's what really gets you going in terms of building up your endurance.
Are there any online classes that people can sign up for if they don't have access to one of these pulmonary centers, that they would be able to follow a regimen or, get specific advice on how to do this at home?
That's a good question. There probably are. I will try and find out.
I
will find out and let you know.
Yeah, I think in the era of online consultations, I think that's something that we've talked about on a Mount Sinai hospital system level, of making these kind of things available, group sessions, not exercise, but just in general for that. But yeah, it's something that as the world changes toward an online world, that's a great idea, something that we should work towards.
Yeah, no, I think that there are some downsides to telehealth, but there are definitely some huge potential upsides. A lot of people having recurring terrible headaches, like your head is in a vice. I felt like my brain was going to explode out of my head, and I still get those from time to time. I know that's not related to either the heart or the lungs, but any advice?
So as we'll say, we'll go back in individualizing to therapy means, right? So is it from a migraine, or is it from hypertension? You got to be checked out. So it's really hard to give you a blanket.
You have to go. Okay, you have to go to the doctor. Okay, last question. For people who are living in the parts of the country who are now not only dealing with the pandemic, but they're also dealing with wildfires, the smoke has to be making people's lungs worse. I mean, it can't be making the recovery any easier, right, Dr. Steiger?
Yes.
Any advice for these people other than, there's nowhere to go.
Yeah,
How do you do?
It's very unfortunate. It's very unfortunate. So I would say to patients out there who've had COVID, they have to wear a mask. And the N95 is better because the N95 refers to the particle size that the mask can filter out, because when we're inhaling smoke particles, we're inhaling irritants. They may be hot, they may be injurious, they may be damaging, they may have toxins in them that affect the airways. So it's not helping recovery. On the contrary, it's exacerbating the lung injury that is there before. The lung injury is mainly in the airways. COVID mainly affects the lung and the lining of the lung, not necessarily the airways, but it's compounding pre-existing injury sustained by COVID. So patients obviously ideally have to be away, but most people don't have that choice, so they must wear masks.
So this will be my last question because I know that we've gone over time. We had some technical difficulties I apologize for. So speaking of masks, this is a specific pulmonary question, but since you mentioned it, 2 questions on masks. One is, what kind of mask should we all be wearing? What is the best mask in just practically? And what do we tell people when they say, oh no, masks aren't good for you, they're not good for your lungs? You're a leading pulmonologist. What's the line that we give back to explain why they need to be wearing a mask and that it is not unhealthy and so on and so forth?
So I will just quote the esteemed Dr. Fauci.
Always.
Who unequivocally, I saw that, who unequivocally recommends, as the CDC does, the use of masks. Masks both decrease the risk of a contact getting infection from you and protects you, the wearer, from getting exposure from a person. Second question, what kind of mask? Well, if you're in a high-risk area, let's say myself as a healthcare worker, either in the hospital or in the clinic where I don't know the status of a patient who's coughing, it may be asthma, it may be COVID. All right, patient may be asymptomatic and have COVID. So we wear N95 masks. And I wear goggles as well. So if a patient is really concerned about traveling on a subway or public transport or being in a crowd, they should both wear a mask and wear goggles as well. They should be cleaning their hands. For general use, going shopping, etc., we all have relative comfort levels about risk. Everybody should be wearing a mask. Surgical masks, thinner material, they don't filter out as much, but if you respect social distancing, you're not in crowded stores, okay, and everyone's behaving themselves and wearing masks, a regular surgical mask may be sufficient. For high-risk areas, you need to wear an N95.
And especially, and if there's smoke.
Yeah.
Okay. And when the person in your town Facebook group or whatever it is saying that masks are, bad for your lungs because you're rebreathing, and you can't exercise and all that stuff, not true, right?
I'd say the following. Masks are uncomfortable. Of course they are, which is why some people don't. I beg pardon?
The question isn't, are they uncomfortable? Are they dangerous?
Not at all. My patients with pre-existing chronic lung disease, they know they have to wear a mask. So the bottom line is masks work. There have been studies shown in hospitals where when staff started using masks, their infection rates significantly fell. Masks work. And when we look at countries where there's policy of universal mask wearing, their prevalence rates are much smaller. And social distancing and hand washing, etc.
And on a practical level, I see about now 30 COVID patients a day. I wear an N95 mask. I don't have any antibodies. I haven't had COVID. So it works. And I think everyone on this call, everyone on this knows this already. And I think it's a matter of, it's important that you say that it doesn't actually harm you. You're not rebreathing your carbon dioxide. You're not putting yourself at any risk.
And sometimes it's just good to be able to say, well, I just heard from a leading expert and let me explain to you why you are wrong, because that's where most people in this group are probably going to be. They just to have the armor, just to have the weapon in their pocket. Well, thank you both very much. Do you have any closing remarks? Anything that we did not, I mean, we have a million questions we didn't get to, but anything that you wanted to address?
I would just say for those patients who are still suffering symptoms, it's real. We know it's real. And there are things that we can do. They need a full evaluation by cardiology, by pulmonary, and all the other disciplines I've mentioned. It's a multi-system disease. There are things we can do to help. Do not be afraid to seek help. And Mount Sinai has resources, and we're available. Just getting back to masks, it's not a political issue. It's a public safety, it's a public health issue.
Yes.
In the hospitals where I work, most of us have tested negative for COVID, and we were on the front line. And some of my colleagues were in the ICU every day. And by wearing masks and sometimes goggles and gowns if necessary, our infection rate is very small. So it's a remarkable statistic. And I do remember
Where I got it from
Yeah.
one unmasked, I mean, this was before people were told to wear masks on
Yeah.
March 9th,
Yeah.
but one unmasked encounter in a closed room, sitting across the room from somebody, and everybody in the room caught it,
Yeah.
and one person died 3 weeks later.
So I would say to our colleagues, do not be complacent. We're in this for, unfortunately, a few more months. So crowded restaurants, avoid them. Crowded places, avoid them. You know, make sure that you're wearing masks, respecting social distancing. In Wuhan, where it all started, hospital workers were dying. When they started wearing masks and gloves and goggles, etc., their infection rate massively fell, massively.
Dr. Bander, any closing words?
I just think that, again, our COVID center is open. We're working together across the system to make ourselves more available to your group and to other patients that need us. And again, just one last word. Again, the Antibody Drive is really important to us. It's really helping patients live in this current phase. So thank you for your support, and we'll see you, hopefully some of you at the event.
I hope we will see all of you, or as many people as live in the New York area next week. And I'm going to go over onto the page right now and post all the information so you can go sign up. Thank you both very, very much for your wisdom, for your leadership, and for your acknowledgement. Just hearing doctors say, we believe you, and this is real, and this is not in your head, is more valuable than you can possibly imagine. So thank you for your faith and for everything else. And we look forward to having you on again soon and us all learning together. Thank you.